And I'm a neurosurgeon with my home base in Wichita Falls. And I have satellite clinics in Jasper and Vernon. I am really excited to be here. I was so excited to give this talk that I was willing to do it on January 29th. And if you haven't, hopefully you've forgotten, that was the snow.
Yeah.
And we were still going to do it, but the center was down, so I haven't changed the date. But thanks for coming. I am really excited about this. I'm a surgeon, and I went into surgery for, instant results and instant gratification. And the medical side of things like diabetes is something that it's a long-term problem, and that's not my lane. But what I'm going to show you today is pretty exciting because I do have something to say about it. It's a major update for people who are suffering with diabetic neuropathy or nerve pain. So first, like I said, I am a neurosurgeon. I do spend a lot of time talking about how I'm trying to give surgery a good name and only offer it when it's really a good indication. But in talking about things that aren't surgery, like spinal cord stimulation, people forget that I do surgery. So just to let you know, a disclosure here, I'm a neurosurgeon. I do spinal surgery. I have no financial disclosures. I have no relationship with the stimulator company. And to keep it free from commercial bias, I'm not going to mention the name of the stimulator company that I use. So here's the outline. We're going to just do a brief history of the treatment and the recommendations and the medications for painful neuropathy. Then I'm going to talk about a trial, a clinical trial that really changed everything. I'm going to warn you that my slide does have some graphs and data in it. And if anyone wants to geek out about the graphs and data, we can do that afterward. But I'm really going to kind of go quickly through that. It's not supposed to be intense as far as technical data. The results are pretty clear and obvious, and I'll show those to you. And then we'll talk about SCS, which is spinal cord stimulator, what it is. And then finally we'll wrap up with what the indications are and how stimulators are used. Okay, so first, the history of medications for nerve pain. So there's basically three. There's Gabapentin, also called Neurontin, there's Cymbalta, which is fluoxetine, and then there's Lyrica, which is pregabalin. And I'm going to put some slides on here that have some words and data on it, but I'm going to put it all together on a timeline, so it should be pretty easy. In general, gabapentin was first discovered in 1975. It was actually supposed to be a seizure medicine, but it's not a very good seizure medicine, but people noticed that it helped the neuropathy in their feet. So it was approved for shingles or another kind of nerve pain in 2002, and then it was mentioned and mentioned by the American Diabetic Society and also the American Academy of Clinical Endocrinology for diabetic pain. Now, all of these, the next medicine is Lyrica. Again, it was approved for shingles type pain in 2004, and it's been mentioned along the way as a possible recommendation from the diabetic societies. And then the last one is fluoxetine. This was actually a medicine for depression, so there is some stigma. People will say, well, why are you using this medicine? You think I'm depressed, but it actually is pretty well known to be a decent medicine for neuropathy pain. And again, the ADA and the Endocrine Society also have mentioned this. So here is the timeline. In general, we got 1990 going up to 2020. Really the last 20 plus years, we haven't had much. We've got gabapentin and Lyrica getting approved for different things. Technically, gabapentin is still off-label for diabetic neuropathy, but it's what we had, and it worked pretty well for some patients. The mentions by the associations come a little later, much later than when doctors were actually using them. And if we had any PCPs in the office, they might have a different story about what happened in the early 2000s. But for the longest time, this is what we have. You try these medicines, if they work, and they do work well for people, that's great. If not, sorry, that's all we have for you. So you can see down here that there are some people this works really well. But for everyone else, either not tolerating the side effects or not really working that great, it's just kind of been, oh well, I guess I just have to live with it. Everything changed when this study was done, this Senza study. And so this is 2020 to 2026, and here we are at the end of the timeline. In April of 2021, a study was done on peripheral diabetic neuropathy, and it was published in the Journal of American Association Neurology. it was very rapid after this study that the FDA approved it. Now, in this slide, you're going to see the wings of my logo from Excelsis. Anytime I put in the wings there, I want to focus that this is called high frequency. High frequency means 10,000 hertz. Some companies say that they have high frequency, but they're below 1,000. So this is like super high frequency. So I want to make note that the recommendations from the society and the studies were going with 10,000 hertz high frequency. So it was a rapid approval by the FDA, and then it took a while, but it was more rapid than the medicines for the American Academy of Clinical Endocrinology and the American Diabetic Association to actually update their standards of care. And so here's just a little brief thing from the ADA of the ways you can treat things. And it's a multimodal approach. Some is diet, exercise, control of diabetes, topical creams. And over here are the non-medicine therapies. So again, exercise and diet. And then energy or nerve stimulation, high frequency spinal cord stimulation. The next one isn't as pretty. It's from the American Academy of Endocrinology. But ultimately, in their guidelines, they basically say that high-frequency spinal cord stimulation in combination with other approaches should be considered for refractory, painful diabetic neuropathy. So next I'm going to talk about this Senza trial. And again, this is going to have some graphs in it, and I'm happy to go over it afterward if you'd like. But first off, this is not a small journal. This is JAMA Neurology. Now the study trial was this. They basically took 216 people with painful diabetic neuropathy that hadn't responded to medicines, and they put them into the study and they split them into two groups. One was regular care and the other one was a trial of a spinal cord stimulator. And what they found was, you can see that this is the basically pain relief scores. So the dark bars are the stimulator and the orange bars are the regular management. And the statistics all work out, but visually you can see there was much more pain relief with the people that had stimulators. And on the right, it shows the same thing. Reduction in pain over time from baseline to 6 months. And you can see that the dark bars, which is the stimulator, have much more reduction in pain. Now, they also did some functional scores on sleep and just overall global function. And you can see that they have the same differences as compared to the regular care. Lastly, this is global assessment of function and patient satisfaction. You know, the number of people very satisfied or satisfied was higher in the people that had the stimulator than people that did the usual care. Now, there were some follow-up studies that came, like an 18-month and I think a 12-month and an 18-month, because the original study was only 6 months. And so what they found was that overall, people who tried the stimulator, 85% were responders, and there was a 73% average pain relief. Another study actually looked at things that weren't really pain relief. They were just how much, what are the sensations? And so you can see on the left here, you know, numbness, tingling, burning, and cold sensations from baseline to 12 months. Patients reported that all of those things, I mean, on average, not everyone did, but on average, all of those things were improved. Lastly, another interesting one is that after the 6 months, they took the people that didn't get randomly put into the group and they said, do you want to try the stimulator now? And a high percentage of them said yes, please, because they signed up thinking they might. And they did something called crossover. And so they went on to have the stimulator. And so this yellow line shows them, you know, not having a reduction in pain. And when they crossed over, they basically achieved the same results of everyone else. Now, adverse events, meaning complications. This is it's more of a procedure. It's done in more. I'll explain more of that later. But it is an invasive procedure. So anytime you poke the skin, you can have an infection. And essentially, the complications that they have are basically infections where sometimes the stimulator had to be removed. The complication rate was no higher than any other time that you would poke the skin with a needle or do a small surgery. So next we're going to talk about, well, what is spinal cord stimulating? It might surprise you to know that we've been stimulating the spinal cord since 1967. And I started med school in 2002. It's gotten much better since 1967, and quite frankly, it's almost exponential. The new programs come out, the companies are competing with themselves on different programs, and stimulation has just gotten better and better and better. In fact, it used to not be so good for back pain. But because of the programming changes, not only can they help pain in the legs, but also for the back. And I do most of these types of procedures for people with back pain and or leg pain. Now, the stimulator it basically consists of two leads or wires that are placed into the body. They're in a certain place in the body, near the spinal cord, but not in the spinal cord. So under the bone, but not in the spinal cord, in the epidural space. And I'll explain that on the next slide. And the leads need to have some kind of energy or a battery. Now, traditional stimulation, the old-fashioned stimulation, was something called tonic stimulation. And the more you turned it up, the more you could feel the buzzing. Some patients like that, but most patients didn't like that, and they would have to turn down their pain relief to tolerate the buzzing in the feet. The 10,000 hertz high frequency, it doesn't matter how much you turn it up, you're not going to feel the buzzing in the feet. So that was a big benefit when that stimulation came about. So what is the dorsal column? So we talk about the body in terms of a ventral or front side, or a dorsal or a back side. You can think about the dorsal fin of a dolphin is on the back side. So the dorsal epidural space is from the back, so it's easily accessed. And you can see here, this is an epidural needle. You've heard of epidural anesthesia for childbirth. So it's an epidural needle that places this in the epidural space. So the way the spinal cord works, luckily for us, is that the information going down and controlling the body is in the front. The information coming up from the body to the brain is in the backside. So this would be the backside, and this space right here is the epidural space. That's where the stimulation is occurring.
I don't see any discs. Where's the disc?
Okay, so the spinal cord stimulator lead placement. So again, these are small wires about the size of a spaghetti noodle placed with the needle. Like we said, I put a needle here just to show that this is not a surgical procedure. So the needles are kind of targeted so that they come in and it just gets right underneath the epidural space, much like you do epidural anesthesia. The target is actually the 9-10 space in the spinal cord, and we measure that based on which rib is coming in. Now, there's a trial, so this is unlike surgery where after the surgery is done, if it didn't go like you liked it, you can't not do it, it's already done. This is a trial, this is a test trial, it's a 1-week trial. The leads are placed in the body, but the battery's on the outside of the body. The leads are removed in the clinic, and a Band-Aid is placed. Now, if patients like it, then the leads are put in, and the leads are buried under the skin deep, and a battery, like a small pacemaker battery, is placed typically in the flank area. So, what are the indications? So, who qualifies for a trial of spinal cord stimulation? It's pretty simple. If you have diabetes and your pain is greater than 5 out of 10, I don't like the pain score. I don't ask people what their level is. They're not going to come see a surgeon unless it's really bothering them. But basically, you have to have pain that really bothers you for longer than 3 months, which is the definition of chronic, and have tried at least 2 medications prior. If you have that, then you qualify. There is one little catch. You do have to do a neurocognitive testing. I don't know where that came from, but it's been around forever. And then insurance will include it. So yes, is it covered by insurance? Yes, it is. So the temporary trial. So one, it is performed at the hospital. It's a same-day procedure, so you go home the same day. There's no incision. It's just a needle poke. It's a 1-week maximum trial. That's because of risk of infection. And the lead is removed in the office again, just like an IV, and a Band-Aid is placed. You can end the trial early if you know that the trial is successful. And I have had patients come in early so that they can get the paperwork started for the permanent. In general, most people that do the trial really like it. There are some people that don't respond, and they say, I didn't notice much of a difference. But a lot of patients, when it works really well, and I have had a lot of patients saying, please don't take it out. The permanent is a little bit more of a surgery because you do have to make a skin incision, but it is also in the hospital, go home the same day. The small incisions are one to bury the wires after the needle poke, and also a small incision to hide the battery under the skin. So we are talking about like a skin deep type of procedure. And then, so here's the conclusion. If you have diabetes and you have controlled your lifestyle, modified your diet and exercise, and other therapies, including 2 medications, have not helped to your satisfaction, then a trial of the 10,000 hertz high-frequency spinal cord stimulator is an option.
No diabetic.
And that's it. Are there any questions or any slides you want to see?
This is only for diabetics.
Yes, so the trial was done on diabetic neuropathy, and that's a little bit unfortunate. It's neuropathy with diabetes is very common, but there are lots of people that have horrible neuropathy pain in their feet, and it's just out of nowhere, idiopathic, or maybe post-chemotherapy, or maybe something else. So for those, so for those patients, unfortunately, they don't meet the criteria. This criteria, however, it is indicated for certain types of back pain and any kind of pain that would be down into your legs. So I have met patients who had neuropathy pain that wasn't diabetic, but they also had some other type of pain, and they qualified for the stimulator for, say, back pain. And then the stimulator for them, it was kind of like 2 birds with 1 stone. I've had the opposite effect. I saw a patient primarily from a podiatrist for neuropathy, and after I got to know her, even before the procedure, it turns out she has lots of back pain. And for her, the stimulator helped her neuropathy, for back pain, and some other leg pain symptoms. So it was like 3 for 1 bird. So if you don't have diabetes but you have neuropathy, there are some other indications. And yes, this stimulator will cover it, but because of the system and approvals, we have to see what qualifies.
Pre-diabetic. What about that?
So she asked, what about pre-diabetic? As far as I'm concerned, that would count. But you would have to have tried medicines for it. If you're getting gabapentin or duloxetine for neuropathy pain and have pre-diabetes, I believe that's a close enough qualification. Again, these things are sent to insurance and they decide. But I count that because it is neuropathy pain and diabetes in the name. Okay, well, if there's not any other questions, I'm going to hang out and finish my lunch. I'm happy to talk to anyone here. I do have some pamphlets and whatnot there. But thank you very much.
Thank you.